Welcome to the Value and Innovation Forum briefing on sustaining access and choices for patients, exploring the risks and benefits of traditional Medicare and Medicare Advantage. I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention and co-chair of the Value and Innovation Forum Steering Committee. Medicare Advantage enrollment has grown rapidly over the past decade, and Medicare Advantage plans have taken on a larger role in the Medicare program. Last year, 1/3 of all Medicare beneficiaries, that's 22 million people, were enrolled in Medicare Advantage plans, and the Congressional Budget Office projects that the share of beneficiaries enrolled in Medicare Advantage plans will rise to about 47% by 2029. Recent stories about whether Medicare Advantage is a good fit for all patients made us want to take a closer look at this trend. Our expert panel members will help us and you answer that question. Before we introduce the panel, let me introduce the Innovation and Access Forum. It is a collaboration of nonprofit organizations in order to present timely, important policy issues in a balanced way, providing all sides. A steering committee chooses issues based on what is timely and input that we receive from you. The issues may be nuanced and complex. Steering committee members include the National Forum, the National Patient Advocate Foundation, National Osteoporosis Foundation, Alliance of Community Health Plans, Caregiver Action Network, and Association of Black Cardiologists. We hold these briefings quarterly and welcome ideas for future topics. Now, I'm pleased to introduce a fellow steering committee member, Claire Gill, who will be the moderator for today's briefing. Claire wears two hats. She joined the National Osteoporosis Foundation in 2013 and is their CEO. And in 2019, September of 2019, she founded the National Menopause Foundation. So Claire represents a lot of patients for whom the traditional Medicare or Medicare Advantage question is top of mind. Claire, please take the wheel.
Thanks so much, John. It's a pleasure to be here with all of you and very excited to talk about this very important topic. We have a great panel of experts here to be able to share with you their expertise, and hopefully we'll have a lively discussion at the end of these presentations that will allow us to get your input, find out what issues and questions you still have to share with your audiences, and we can hopefully provide additional information along those lines. You will have a chat feature on your Zoom. I think most of us have become very familiar with that feature over the last several months. So we ask that you please add your questions to the chat, and John and I will take time to go through those questions and pose them to the appropriate panelists to be able to share their answers to your questions. The presentation with Tricia Newman. She is Senior Vice President and Senior Advisor to the President, Director of Program and Medicare Policy at the Kaiser Family Foundation. Thank you so much for being here with us today, Tricia. In addition, we will be hearing from Judy Stein, who is the Executive Director of the Center for Medicare Advocacy. Judy will be presenting following Tricia's comments. And finally, we'll be hearing from Michael. Michael will be discussing the policy importance of Medicare Advantage, and Michael is the Director of Public Policy for the Alliance of Community Health Plans, Michael Bagel, and he will be wrapping up the discussion before our questions and answers. So let's kick off today's discussion with highlights from Tricia.
Thank you, Claire, and thank you, John. And it's really great to be here talking about a very important topic at actually a very important time, because the Medicare Advantage Medicare open enrollment period starts next week. So this is well timed and obviously something that's very important. I am going to give a pretty quick overview of some of the issues involved in traditional Medicare versus Medicare Advantage before turning it over to my friends and colleagues. Can I have the next slide, please? Okay, let's start with a really basic question. What is Medicare Advantage? We've heard about it, but what is it? So it is an alternative to traditional Medicare. This is Medicare Advantage are private plans that are operated by private insurance companies like United Health and Humana and others, and they offer HMOs and PPOs primarily. Beneficiaries have the option of choosing between traditional Medicare and among the Medicare Advantage plans during the annual enrollment period, which is 6 weeks starting October 15th. The government, Medicare, pays private insurance companies a fixed amount per enrollee with some adjustments to provide all Medicare covered services. Plans are required to cover all Medicare covered services, and most also cover Part D benefits, that's the prescription drug benefits, and many cover extra benefits, which I'll get into in a minute. You may have heard about there's a Part A of Medicare, there's a Part B of Medicare. Sometimes people refer to this as Part C, and then there's Part D, the drug benefit. The difference here is that Part C, or Medicare Advantage, doesn't have its own financing system in terms of premiums and payroll taxes. Can I have the next slide, please? You just heard from John about the growth in Medicare Advantage, and this shows you just how steep the climb has been, not just in absolute numbers in millions of people in the program, but also as a share of the total population. More than a third of all people on Medicare are enrolled in a Medicare Advantage plan. The numbers can differ a little bit depending on how you do the count. If you look at people who are enrolled in both Parts A and B, the share is even higher. So Medicare Advantage has now become a major part of the Medicare architecture. It is no longer just a small share like it used to be in the earlier days, in the late 1990s, when it was just an option for people. Now it's really a very important option, and will continue to be. Can I have the next slide, please? Here you see a map of the country, and this is by state, and what it shows you is that Medicare Advantage penetration varies enormously across the country. If you look at a state like Florida, you can see it's a state with very high penetration overall compared to some of the states that you see flagged in orange, where it's virtually not, it's not a big deal in those areas. Within each state, however, there's a fair amount of variation in terms of the share of people enrolled. For example, in Miami-Dade, about 2/3 of all people are enrolled in a Medicare Advantage plan. So it is dominant in some areas and not really available in others. This really means that the Medicare program, when we've been talking about Medicare and Medicare for all and a public option based on Medicare, I don't think people are thinking about Medicare Advantage in that context. And here you can see it really is quite a big deal in certain parts of the country. This raises lots of issues about the unevenness of what they provide across the country, which I will get to in a minute. May I have the next slide, please? So what about this decision? This is not an easy choice, and I can tell you based on people I talk to, they're flummoxed when they go on Medicare and they need to decide what to do. They got a ton of marketing material, and they don't really know whether to choose traditional Medicare or Medicare Advantage. They sometimes don't even know that there's a distinction. It's very confusing about whether Medicare Advantage is offered by the government or private plans, and if so, what are they doing getting all these marketing materials? But there are real reasons and strong considerations. So why traditional Medicare? It's not an HMO or PPO, so there's the broadest choice of hospitals and doctors nationwide, unlike Medicare Advantage. There are very few restrictions. There are restrictions, but not to the extent as they are under private plans, like prior authorization requirements, which are typical in Medicare Advantage plans. When you're in traditional Medicare, you have the flexibility to choose among Part D plans. When you're in a Medicare Advantage plan, you get the drug plan that they offer. Traditional Medicare actually has potentially lower costs, which I'll illustrate in a minute, and less hassle because of some of the restrictions that Medicare Advantage plans have. particularly for people who have supplemental coverage, because then all the payments are sort of done automatically depending on which coverage they have. And there's flexibility to switch to Medicare Advantage each year during the annual open enrollment period, but not necessarily back again if you want a Medigap policy because of guarantee issue restrictions. Okay, why Medicare Advantage? It's kind of simpler in the sense that it's one-stop shopping. No need for a separate supplemental policy. No need for a Part D plan. You come on Medicare, you get it all in one package. It's one insurer for all your Medicare covered services. Why else? Most plans have an out-of-pocket limit that provides some financial protection for services covered under Parts A and B, which provides peace of mind to some. Supplemental premiums for Medicare Advantage plans are generally much lower than Medigap, and many people across the country are offered zero premium plans. And then a big draw is extra benefits, dental, vision, gym membership, and new benefits that have just come on board. Can I have the next slide, please? If we look at what's going on in Medicare Advantage and start from the circles on the top left, which you can see as most plans do offer some extra benefits, which are appealing. Eye exams, telehealth, dental benefits, fewer offer transportation. We could do more, gym memberships, that kind of thing. Hearing. These are a draw. I will say there's a fair amount of variation underneath, and it's hard for people to tell. So if they're attracted to a plan, for example, for dental, they should look pretty carefully because there are restrictions on how much the plan will cover and whether it's a good value to sign up for that. But it is appealing. Going down from there, if you look at the orange lines, you can see that premiums for Medicare Advantage plans, looking at the Medicare Advantage drug plans, which are the majority, have been going down. That too is quite attractive, again, relative to Medigap policies. But you can see on the right side that most plans have prior authorization requirements, particularly for expensive services. And while plans do, looking down at the bottom, those blue and green lines, most plans are required to have an out-of-pocket limit, but they're relatively high. And while that provides peace of mind, there are also concerns for people about the costs that they would incur before they get there. And this is not an issue for people who have traditional Medicare with a Medigap policy that generally covers all the extra expenses once the premiums are met. Can I have the next slide, please? I mentioned earlier, because I think the assumption is that people in Medicare Advantage would definitely pay less than they would if they were covered under traditional Medicare for expensive services like an inpatient stay. And we looked at that because we were sort of curious in the context of COVID in whether or not that's true, because Medicare, as you know, has a relatively high inpatient deductible of a little bit more than $1,400. And what we found is that when we looked at Medicare Advantage plans and the cost sharing that they require, it's true that most Medicare Advantage enrollees would pay less in cost sharing for a short length of stay of 3 days. But as length of stay increases, that story flips. And actually costs would be higher under Medicare Advantage than traditional Medicare for longer lengths of stay. And with COVID, we're seeing lengths of stay, the median is something like 8 to 10 days. So it is something for people to think about. And I think as Judy's going to talk about in a minute, when people choose plans, they tend to choose plans thinking about their current status. So maybe when they're healthy, not when they are sick. And I think where the rubber hits the road for people in terms of expenses is when they're sick and they incur high costs. So it makes the choice really difficult because people are not thinking about, well, what if I need an expensive medication because I have rheumatoid arthritis, or I have cancer, or I have MS. People are often making these choices assuming the best, and unfortunately, people do get sick as they get older and incur costs. Can I have the next slide, please? Not only is it complicated to choose between traditional Medicare and Medicare Advantage, but it's pretty hard to choose among Medicare Advantage plans. The average Medicare beneficiary has a choice of 28 plans in 2020. I wouldn't be surprised if the number is bigger next year. We haven't done the calculation yet. And in some counties, I mean, there's just I would say, a crazy number of plans given how hard it is to choose. With the two examples we have here, LA and Cleveland, where people have a choice of more than 50 plans. If you look at the work of behavioral researchers, they say there's no way people can sort through all those options. So many people just don't choose. Can I have the next slide, please? And if you are going to choose wisely, here is my list of things that you need to think about. It's probably not exhaustive, but you need to think about premiums. That's the simplest thing. Cost sharing, provider networks, extra benefits, quality ratings, prior authorization restrictions for things that matter, that may matter. Then you go to drugs, because they're also covered by Medicare Advantage plans, and you would need to think about the same thing you think about if you're in traditional Medicare, choosing among Part D plans. And by the way, there are dozens of Part D plans available to people in traditional Medicare, also hard to choose. Which drugs are covered? How much do you pay for the drugs that are covered? What tier are they placed on? Are they preferred or not? Are there separate prior auth and other cost sharing, cost management tool restrictions for the drugs that you might be taking? What about preferred pharmacies? What about savings are not related to mail order? It's really hard to do this. If you're a very wonky person and you go on the Medicare Plan Finder, this might be fun for you, but this is not fun for most people. And so most people actually just kind of make a choice when they first go on Medicare and they stick with it. And that can really cost them a lot of money. If I could make money on all the savings that I have helped people realize in my family and extended network, I would be really happy to have the money in my pocket, because people are just sticking with what they have, not really thinking about how plans are changing and their needs are changing. Can I have the next slide, please? And this is just sort of making the point that very few people switch. They go on Medicare, they do their hard work, they decide whether they're going to be in traditional Medicare, Medicare Advantage, and then they stick with what they have. And we did focus groups, and I just thought these were kind of very sort of apropos quotes. At my age, as we get older, we've learned that the grass is not really greener on the other side. We're cautious about changing. People are cautious about changing. They don't trust their ability to make these decisions, but they matter, because it affects whether their drugs are covered, whether they can see their doctors, and how much they pay. Next slide, please. So I'd be happy to take more questions, but we were urged to be brief. I'm going to turn this over to Judy Stein. Thank you.
Thank you, Tricia. This is Judy Stein. I'm the Executive Director of the Center for Medicare Advocacy, and I'm going to highlight and add to some of the things Tricia just mentioned from the point of view of an attorney advocate for Medicare beneficiaries, which my organization, I have been advocating for beneficiaries since 1986. Next slide, please. So just so you know, the Center for Medicare Advocacy is a national nonprofit law organization, and we work to advance access to comprehensive Medicare and quality health care. And you'll see on all the slides our website, medicareadvocacy.org. I urge you to go there for more information. The only thing we focus on is what's going to be best for beneficiaries and hopefully best for taxpayers at the same time. And we focus on the needs of people with longer-term debilitating and chronic conditions. Next slide, please. So originally, Medicare was intended to be an insurance model, indeed a social insurance model. I think that's important because the notion was that we would be all in, that all people 65 and over, and in 1972 they added people with disabilities who are getting Social Security disability benefits, that all people well, not well, older, and very old from all over the country would pay in and take out and would all look out for one another in a social insurance model, which paid for some of the costs of some health care under clear criteria. Beginning in the 90s and then renamed Medicare Advantage in 2003, private insurance companies came in and under what's now called the Medicare Advantage program. Next slide, please. Just a quick look at who we're trying to insure under these insurance companies. So who are Medicare beneficiaries? First, as Tricia indicated and John mentioned, there are 62 plus million Medicare beneficiaries throughout the country. I think it's important to note that they tend to not be high income. I think this is lost on many Americans. 50%, thank you Kaiser, have for these stats have incomes below not $30,000, and a full quarter have annual incomes below $17,000. Few have significant savings, and 10% are in debt. Next slide, please. Further to thanks to Kaiser Family Foundation, the slide here demonstrates the great need that Medicare beneficiaries have. When we're trying to insure this population, we're talking about people who are by definition older and or have disabilities. A full 32% have functional impairments, a quarter report themselves in fair or poor health, and another almost quarter have 5 or more chronic conditions. So this is a very a population that's in great need of good health insurance. And further note that full 12% now are over 85 or older in this population. Next slide, please. Now, as Tricia mentioned or spoke about, Medicare Advantage is an alternative to the traditional Medicare program by which people should get at least all the benefits available under traditional Medicare through a choice of a private insurance plan. Most of these plans, most enrollees, I think it's about 2/3, are enrolled in HMO models which have provider networks. That is, the choice of providers is going to be limited. Congress has, over the last number of years, been expanding the scope and flexibility for Medicare Advantage, as has the executive branch, the administration, in a way that is not necessarily true for traditional Medicare. For example, you may have heard that they've added some in-home benefits, but we want to make sure people know that they need to look at the fine print, because some of the new benefits may be limited to certain cohorts, people with certain conditions, not available everywhere, or you may have to pay more for them. Next slide, please. So what's all this conversation about choice? Well, as Tricia clearly spoke, a lot of people do not make a choice from time to time, namely every year. Medicare Advantage enrollment is highly concentrated. In 2020, most beneficiaries are in plans operated by United Healthcare, Humana, and Blue Cross or Blue Shield affiliates. Nearly 1 in 5, 20%, are enrolled in MA not due to their own choice, but the choice of their former employer, and it's a result of retiree coverage. And while choice is actively promoted in the beginning in the open enrollment period, as Tricia mentioned, which is about to begin on October 15th, most people, once they make a choice, do not make a change. In fact, under 10% change, and we find that true even though the plan or option they chose is no longer really meeting their needs. Next slide, please. One problem that people want to make sure they're aware of when making a choice to be in a Medicare Advantage plan is, or one concern to look at, is whether your physicians and healthcare providers are going to be in the network, in the list of providers that you can see in an MA plan. There are increased options regarding the source of benefits. That is, Medicare Advantage gives you different sorts of private plans to choose from, but doesn't increase the number of healthcare providers that you'll be able to see when you need to do so. And in 2021, we see that there is some weakening of network adequacy requirements by the administration. And we want to make sure people are very aware, as we increase access to telehealth during this time of COVID, that sometimes telehealth, as opposed to seeing or going to particular providers, may equal network adequacy in a particular plan. Next slide, please. Now, most Medicare Advantage plans will require prior authorization. That has increased from 79% in 2019 to 99% in 2020 for most services. For most healthcare services, members of Medicare Advantage plans will have to get prior authorization. This is generally not true of people in traditional Medicare. And the studies have found that there are so many denials in the initial stages that the Medicare Advantage plans, if people do appeal, overturn those denials 75% of the time. We also know at the Center for Medicare Advocacy and the OIG has found that only 1% of people actually ever do appeal. So we want to make sure that people know that prior authorization is not an extra benefit, but can be a barrier to access. Next slide, please. Further, as Tricia well knows, there is an article in New England Journal of Medicine which showed that there was no real difference between Medicare and Medicare Advantage plans with regard to true care coordination, which is often a selling point for Medicare Advantage plans. And people with greater levels of disability or illness generally switch or make an effort to switch or stay in traditional Medicare. Next slide, please. This is a decision tree which we created at the Center for Medicare Advocacy to help people choose between Medicare, traditional Medicare on the left, and Medicare Advantage on the right. This is available. I hope you'll print it out if you think it might be helpful for people you're trying to help. But it also shows the complexity of what has occurred as a result of all the different options for people when they do make that decision as to how to get their Medicare benefits. So we welcome you to use our decision tree when helping yourself or someone else make this choice. Next slide, please. Now, in traditional Medicare, as Tricia said, there's greater flexibility and choice of providers. Most providers, healthcare facilities, hospitals, nursing homes, home health agencies, and physicians throughout the United States participate in traditional Medicare program. Let me say that the Medicare program often refers to this as original Medicare, and I'm afraid still sometimes calls it fee-for-service Medicare. Traditional Medicare is the public program which is available to all over the United States. It is true that there is cost sharing and that people will best be served if they have a Medigap plan, also known as a Medicare supplement plan, to help pay for the cost sharing in the event that Medicare says it will cover, but there is a copay or a deductible. Medigap plans, except for in 4 states around the country, are not available all the time to people who choose to leave traditional Medicare and return to traditional Medicare. So it can be another reason to be very, very cautious if you join a Medicare Advantage plan and think you may want to re-enter traditional Medicare. You'll want to make sure that you can do so by joining a Medigap plan in your state. You also want to make sure that if you think you might want to travel to family or friends, or that you do travel or might want to get care in a facility outside your geographic area, that you stay in or go to traditional Medicare. That will be less available to you in Medicare Advantage. I'm going to skip now, if you can, Jen, to slide 31 to sum up what I think is very important. You'll see as we skip through some of my slides, there is, we think at the Center for Medicare Advocacy, some switching, steering to Medicare Advantage in this enrollment period and in the past. You'll see a slide I have shows a very healthy older gentleman about to take a run and talks about choosing your plan. What you're choosing is how you will get your Medicare, through traditional Medicare, or do you want it through a Medicare Advantage plan? When making that choice, make sure you make the choice based on the fact that you will get sick. We get sick. Human beings get sick. And you may get injured. If these circumstances occur, what would you need and where will you prefer to get the services and to get recuperation as well as care for the initial sickness or injury? What will serve you better, traditional Medicare or Medicare Advantage? I thank you very much. The next slides provide resources at the Center for Medicare Advocacy and an ability to sign up for our free, next slide, webinars and weekly alert. And now I'm happy to turn this over to my colleague, Michael Bagel.
Well, thank you, Judy, and thank you, Tricia, before. So I'm Michael Bagel with the Alliance Community Health Plans. If you go to the next slide, please. So we are a membership organization. We have 25 community-based nonprofit health plans across the country. We are in 35 different states in the District of Columbia, as you can see on this map. But I want to underscore who ACHP members are, all of which, except for one, offer a Medicare Advantage product, and why when we talk about the choice of Medicare Advantage, specifically those offered by our members, it can be an important choice for consumers and for beneficiaries you may talk to. So let me start with how many members we have. So we cover more than nearly 23 million covered lives across the country, across lines of business. And in Medicare Advantage in particular, we offer some of the highest quality contracts, and we're going to talk about the quality later on across the country. So much so that most Medicare Advantage beneficiaries in the country, 29%, are in contracts or in plans that are rated 4.5 stars or higher. For our members, for those in ACHP, that's 78%. So 78% of consumers who enroll in a Medicare Advantage plan offered by an ACHP member are in a 4.5 star or higher contract out of 5, which means they're getting very, very high quality coverage and care. Next slide, please. So Tricia touched on this earlier, but I wanted to focus on the Medicare Advantage growth projection. And frankly, where I think there's been under projection by some organizations, including the astute Congressional Budget Office. When we changed from what was formerly called Medicare Plus Choice under the Medicare Modernization Act of 2003 to Medicare Advantage, the thought was, well, we'll see a little bit of increase, and it skyrocketed. In 2010, when the ACA passed, there was a thought that Medicare Advantage, because of what the law changed, would depress enrollment significantly. And we've seen the opposite. Today, if you look at those eligible for Medicare Advantage, more than 4 out of 10 seniors or those with disabilities choose it. And according to Avalier, within the next 10 years, it's going to be more than 2/3. That is a huge spike and right along the lines of where we project them to be. A lot of this, though, reflects what you may hear from your consumers, which is as baby boomers retire, and there's more than 10,000 of them a day becoming eligible for Medicare, they're used to either an HMO or a PPO delivery of care through their employer-sponsored care, the majority of them. Or maybe they're receiving care on the exchange or through Medicaid, which also may be from a managed care organization. And therefore, they are used to this style of care, which is why we continue to see its popularity grow. Next slide, please. So this is a map. I know we talked about the percentage of people in each state that have Medicare Advantage, but I thought we'd show some of the real numbers. And you can see across the country that every state has tens of thousands, if not hundreds of thousands, if not millions, of consumers choosing a Medicare Advantage plan across all states in this country. And 31 states in particular have more than 30% enrollment, as Tricia mentioned at the beginning, which, as we continue to see more and more growth, will continue to go higher and higher in the next several years. Go to the next slide, please. So I want to talk about how Medicare Advantage is different than fee-for-service or traditional Medicare, and some of the successes that we've had. And I want to begin, before I do that, noting that not every Medicare Advantage plan is treated equally. There's not one size fits all. As we go back to the original slide I talked about, the members of the Alliance Community Health Plans are high quality delivery of Medicare Advantage contracts. And so you need to be very careful when you look across to make your selection that you are taking that in consideration, because the things I'm going to talk about here, these are average numbers across the whole system, but in particular, those plans scoring higher in the quality ratings will see more of these successes across clinical delivery, satisfaction, quality, and costs. So in particular, Medicare Advantage plans have almost a 30% fewer avoidable hospitalizations, with greater spending on primary care, less emergency room visits, and importantly, less complications for diabetes, which is one of the largest chronic conditions Americans struggle with every day. These are just a couple of the clinical successes that Medicare Advantage plans have had. Probably most importantly, 98% of enrollees stay in the program every year over year. As mentioned, you can choose to go every open enrollment back to traditional Medicare, and most of them stay in the program. Some of that may be a paralysis of choice. I would like to say more of it's due to the high quality and of the care they deliver and their satisfaction. And when surveyed, patients are more likely to say that they prefer MA compared to traditional Medicare. On quality, unlike traditional Medicare, which is something that, frankly, we should probably look to change, Medicare Advantage plans are rated for quality, right? And seniors and those who are eligible for Medicare can choose their plan based on quality. And we've actually seen a lot of movement here. Before the Affordable Care Act passed in 2012, there were less than a quarter of enrollees were in a 4-star or higher plan. That number is flipped. More than 70% of people in Medicare Advantage are in a plan that's 4-star or higher, meaning folks are really interested in the quality and shopping based upon it. And when you compare Medicare Advantage and traditional Medicare on some clinical quality measures, Medicare Advantage outperforms them on every single one of them. And then from a cost perspective, I know we talked about capping out-of-pocket spending. That's very important, especially for new beneficiaries who don't know when they're going to get sick or when they're going to need coverage, to have that guarantee every single year. And the vast majority of beneficiaries don't pay anything for premiums and save annually on out-of-pocket savings in the aggregate compared to others. This while they're getting additional services, which we'll talk about on the next slide. So just as you compare, and this is a generalization, this is not true for every Medicare Advantage plan. I need to make sure that's quite clear. We need to, that in general, Medicare Advantage offers out-of-pocket spending caps, coordination, a lot of the additional benefits, the common ones being hearing, vision, dental, but now also including things like transportation, meal delivery, telehealth services, whatnot. They are rated for quality, which is very important to be able to select based on quality ratings, everywhere from outcomes to process measures to consumer satisfaction. And they're being more innovative on supplemental benefits, and that's true plan by plan. So I encourage you to look really thoroughly at all of these categories when choosing which Medicare Advantage plan is right for you, if it is right for you. The next slide, please. So I thought I'd give some real tangible examples about some of what ACHP members are doing that for their beneficiaries in their plan. So you can see some of the innovative supplemental benefits that they're offering, if not free of charge, at very low costs. So we have a plan up in Wisconsin, Security Health Plan. And for those who've ever tried to get a hearing aid or a hearing assistive device, and those are two very different things, the cost can be very expensive. We're talking $5,000 plus oftentimes for a hearing aid. And this plan is offering them for $250 to their beneficiaries. And they're really noticing that it's helping combat loneliness and social isolation, which at a time of COVID is extra important to make sure you stay connected to folks. Up in Maine, ACHP has a member, Martin's Point, for instance, who really helps seniors live in their homes, so stay in their communities, not in institutions, and have a focus on heart failure and other conditions, where they send nurses to the consumer's home to treat them where they are, with the services they need, with the doctors that they know. And UPMC, based in Pittsburgh, Pennsylvania, is very much focused on diabetes and discount medications, which we know can run hundreds, if not thousands of dollars to beneficiaries a year. And we talked about diabetes at the beginning. They're offering diabetes insulin supplies for just $84, not for a month, but for the entire year. So a person with that condition really has the assuredness that they can receive their medications at an affordable cost, especially given the fact that we do know, as Judy mentioned, that many Medicare beneficiaries live on very low incomes. The next slide for me, please. That is where I will get into, I think, more into the discussion, but I just want to end with one note, which again is one size does not fit all in Medicare Advantage. One size does not fit all for every consumer. They need to make the wisest choice for them. While there is a lot of market concentration in some of the large national plans that were mentioned, United Healthcare, Humana, Cigna, one of the Blues plans, do want to encourage you to look at your community-based plans. Community-based plans that can offer higher quality and especially are not profit motivated, all considerations in addition to the benefits that you should take in consideration when selecting who to go with. And I don't just talk because it's my organization, I just want to tell you we live this. So I have Kaiser coverage. That Kaiser is one of our members. They are the healthcare coverage for me. And for my family who's on Medicare, they choose Independent Health, another ACHP member in upstate New York, for their Medicare Advantage plan. Community-based nonprofit plans and Medicare Advantage can offer a lot, and which should give them some due consideration.
Thanks so much, Michael. I want to thank all of our panelists again, Tricia Newman, Judith Stein, and Michael Bagel, for sharing their expertise with us. I have a whole list of questions. I'm sure many of you do too. We did get some questions in on the chat feature, but I'd like to remind all of you that this is a great opportunity while we have these experts with us to kind of get your detailed questions in. So I'm going to start off with some of the questions we've received so far. And again, please continue to enter your questions during the chat, and we'll try to get to as many of them as we can. Judy, I'm going to start with you. You had mentioned about care coordination, and we had a question about when you were talking about care coordination, were you saying that the MA plans are not providing the care coordination like they're supposed to? And also then, who provides the care coordination under traditional Medicare? Oh, you're still muted, Judy.
So I am. With all of this, the devil's in the details, and what happens in practice is not necessarily what it seems it will be in theory. There was in 2020, a study published in Health Affairs that said that people with disabilities were more likely to switch to traditional Medicare, and one of the reasons for that included the fact that as was reported in the New England Journal of Medicine in 2018, that the difference between care coordination in traditional Medicare versus in Medicare Advantage was not as significant as many people thought it would be when they maybe chose a Medicare Advantage plan. So what does care coordination mean? Well, if you have a good family doctor and you're in traditional Medicare, that family doctor and his or her cohort will be hopefully coordinating your care along with the other specialists if you're seeing them. And if you're in a Medicare Advantage plan, there may or may not be someone who calls from the plan to see how you're doing and checks in on you on occasion. But the actual coordination of all myriad comorbidities, the 5 or more chronic conditions we know that many of these, many in this population have, is not distinguished in terms of coordination between traditional Medicare or Medicare Advantage in practice. And now I think you're...
Myself. Michael, do you have anything you want to add on that about the care coordination in Medicare Advantage plans?
Sure, thank you. I just wanted to note that there's a very different incentive in traditional Medicare versus Medicare Advantage to coordinate care. And I appreciate the study that Judy mentioned, but let me just talk about that for a second. In traditional Medicare, the way that they're paid is based on volume. So they're paid for every individual service they deliver. Medicare Advantage plans, on the other side, are given a one payment per month for beneficiary, a capitated payment, and therefore deliver all the care that that person needs, whether that be more than they expected or less than they expected. And so there's an incentive in Medicare Advantage to be very assertive in care coordination, to be working collaboratively with providers across the spectrum to deliver care to them in a way that prevents, the more expensive hospitalizations, ER visits, whatnot, and do more preventative care. That, of course, also varies plan by plan. Some invest more in care coordination than others. I would say, of course, that our members are much more focused on that. But I would say that the big takeaway is the difference in incentive in how the program is designed in traditional Medicare versus Medicare Advantage is important to keep in mind.
I would like to point out, however, that in most care settings, traditional Medicare providers are no longer paid based on volume, but rather a capitated rate for a set of services during a particular period of time. That's not entirely the case. And so we want to find out whether in practice, a patient who's in Medicare Advantage or traditional Medicare, particular in Medicare Advantage, will actually have an extra service called care coordination.
Okay.
And I don't see that happening very much.
Thanks for distinguishing. Michael, staying with yours, there was a question about on your quality slides based on the ACHP members. Were those for just your members or MA plans overall?
So on the slide, if we can go to it, it's slide 35 for just a second. We have a differentiation between where our members are in terms of quality, in terms of where our members sit versus non-ACHP Medicare Advantage enrollees. So we have a much higher percentage of those folks enrolling in a high quality plan. I did have some stats later on slide 38. Those are across the program. So all those stats are for the average Medicare Advantage enrollee, not specific to ACHP members.
Okay, thanks. And so Judy and Trish, do you know if there are advocacy efforts underway to expand any services under traditional Medicare? And if so, what are those and what are some of the barriers, if any, to being able to achieve that?
Do you want me to speak to that?
Yeah, how about you first, and then Trish can...
Tricia is muted, but I'd be happy to have her go first. Go ahead. I've already spoken. The answer is yes.
The answer is yes, and we are not an advocacy organization, so I can't speak for what we are doing in that sense. But I think over the years there has been a fair amount of attention to the needs of people on Medicare that are not necessarily being met in traditional Medicare, or actually in Medicare Advantage. So I know there's advocacy work that's being done specifically for traditional Medicare, looking at an out-of-pocket cap, because there's sort of no rationale to have one set of people on Medicare entitled to a catastrophic protection, and not another set of people on Medicare. The majority of people on Medicare don't have that same benefit. There has also been advocacy around dental, vision, hearing, and there's also been advocacy around low-income protections and improving those, maybe beefing them up relative to what's available under the ACA. For example, there's an asset test for most of the Medicare savings programs. That said, the biggest obstacle is costs. In the past, Congress has been sort of blocked by budget considerations, and so hasn't moved forward on some of these things that may make a lot of sense because of cost considerations. H.R. 3, which was the House-passed drug bill, included hundreds of billions of dollars in savings on prescription drugs, and would have used those savings for benefit improvements. So there's sort of a thought in mind for moving forward and doing just that. Can I speak to the issue that was just raised, though, for a second?
Sure.
I think teasing apart, really looking at the differences across plans are really important. We're coming out with a report today that shows no difference between Medicare Advantage and traditional Medicare on flu shots, which really surprised me, because I would think plans would have such a strong incentive to keep people from getting sick from the flu. So they would do a lot to support flu vaccinations. We were looking at that in the context of COVID, because we're concerned about whether people get vaccinated. But there's really a fair amount of variation across plans, and incentives, capitation can bring incentives for care coordination, but also into less care. And we really have very little information about how well plans are managing the sickest people on Medicare. And that's what I think will be very important to learn in the future.
Thanks. Judy, do you have anything to add to what Trisha's saying about
Back to the question.
Advocacy, yes. There is my organization, the Center for Medicare Advocacy, and some of our colleaguing advocacy for beneficiary organizations, along with some folks on the Hill, have been working hard to ensure that there's parity between three key areas for traditional Medicare and Medicare Advantage. Ease of access of enrollment, which has become much easier to enroll in Medicare Advantage than in traditional Medicare. Payment per enrollee, per beneficiary should be the same in the same between Medicare Advantage and traditional Medicare. And the benefit packages, be it out-of-pocket caps or whatever dental is provided, should be the same and available in both programs. By the same token, all the marketing and enrollment efforts by the government through Centers for Medicare and Medicaid Services are to equalize the ease of knowing about and enrolling in these two different options.
Yeah,
And
that was
some of the Medicare for All programs definitely look at this, and including a program called Medicare for America, introduced by Representative Rosa DeLauro, would provide all this parity I just described. And then, as Tricia just mentioned, HR 3, which passed the House in December 2019, found savings from drug negotiations and put much of that back in traditional Medicare.
So yeah, that was another question that came up about, we see a lot of advertising even on television for Medicare Advantage programs. That's, not something that traditional Medicare has resources to do. Is there any, work underway to be able to sort of balance out how people receive, the information, so it's, a little bit more information on their choices of both traditional Medicare and Medicare Advantage?
It's an important question. In fact, over the course of the last year, the latitude for marketing has been enhanced by this administration, and there is no equal version of that for traditional Medicare, except perhaps for the Medigap plans, which are also offered very often by the same big companies that offer Medicare Advantage plans. But the fact is that taxpayers shouldn't be paying millions, billions of dollars, I don't think, to advertise Medicare. Rather, the government, through Centers for Medicare and Medicaid Services, should be making it equally available, traditional Medicare and Medicare Advantage information. And then we wouldn't have sometimes 12% more of insurance budgets going into marketing and advertising.
Yeah.
And rather we would spend that public money on services.
So we have another kind of specific question from Sarah. She said that it's her understanding that people who are eligible for both Medicare and Medicaid, they have to choose traditional Medicare. Is that true? And are there any ways to change that rule?
No, that's not true.
That's not true.
It's not true.
In fact, it's not true. And in fact, there are plans that are designed specifically, Medicare Advantage plans designed specifically for people who are dually eligible for Medicare and Medicaid. And the last time we looked, I want to say there's something like 4 million people who are eligible for both Medicare and Medicaid that were in Medicare Advantage plans. Half of them were in special needs plans, which are specifically for people dually eligible for Medicare and Medicaid. But half were just in sort of regular run-of-the-mill Medicare Advantage plans. And I'm not so sure how that works for them, because you would think that the state Medicaid program would coordinate with for each person to make sure they're getting all the benefits to which they're entitled, which should happen in a special needs plan, but I don't see why it would happen in just a regular Medicare Advantage plan.
Trish, I just would add that the individual asked the question I don't know what state she's from, but ought to make sure that she checks in with the state requirements, because some states have, there may be some confusion. States have Medicaid managed care plans, and there may be some restrictions or requirements in the residents of the state of residence that we're not privy to right now. But on the whole, that's not the case.
Thank you for that. So, and I'm still a little confused on the switching back and forth between the programs. Describe how you've all described it. So, can you go over again, if you're on traditional Medicare and want to switch to a Medicare Advantage plan, you can switch to a Medicare Advantage plan, but you may not then be able to switch back to traditional Medicare?
The complication is that you may be able to go back to traditional Medicare, but you may very well not be able to get a Medigap plan.
Okay.
In most states, you won't be able to fully and always get equal access to a Medigap plan.
And why is that?
That's because most states don't have guarantee issue protections for Medigap. So
Yes.
to be really clear, yes, every year someone can go from Medicare Advantage to traditional Medicare. That's absolutely allowed.
True, yes.
But if that person wants to buy a Medigap policy because they want the additional financial protection that it provides, or they want the simplicity of billing, that person may not be able to get it if they have a pre-existing condition, like they need surgery for something, or they have whatever condition. Only in 4 states is that guaranteed. And actually, that's an area where there has been some advocacy on the Hill and some legislation to take a second look at that.
Yeah. And then the reverse, Michael, then if you're on traditional Medicare and you want to move to Medicare Advantage, or if you've signed up and you've gone on to Medicare just as regular Medicare, you can go to Medicare Advantage at some point, again, just choosing from the
During
plan.
open enrollment, yes. So I would say 2 things. So you when you sign up for Medicare, you can enroll in traditional Medicare, Medicare Advantage, and every year thereafter, you have the opportunity through open enrollment, which is October 15th. It starts through December 7th, to enroll in a Medicare Advantage plan, switch a Medicare Advantage plan, or change from Medicare Advantage back to traditional Medicare. Do want to know one thing about Medigap and why this is so important. Congress, in their infinite wisdom several years ago, changed Medigap so you don't have what's called first dollar coverage, meaning that previously you could have a supplemental coverage option that said anytime you owed a copay at a doctor's office, or under traditional Medicare you owe 20% coinsurance, you owe 20% of the cost of the service, you have to pay that out of pocket. Medigap could cover that for you at sometimes a large monthly cost, but maybe it made fiscal sense for you to do that. That's not no longer can be sold to new beneficiaries joining Medicare anymore. It's not an option. If you have it, you get to keep it. You're grandfathered in, but for new beneficiaries, that's not offered. And so one thing that folks need to be very cognizant of doing is sitting down and thinking about, do I stick with traditional Medicare? What is my out-of-pocket cost going to be? And what would the cost of my Medicare supplement be? Versus if I go into Medicare Advantage, I may not have some of those out-of-pocket costs, but I also don't have, I may be paying, different prices for different services, or what do I have to buy out of pocket? You almost have to sit down and do both sides of the ledger and figure out where you lie. I think now, because Medigap took away first dollar coverage, it makes it a little bit more difficult for those who are worried about out-of-pocket spending to stay in traditional Medicare.
I think that's, however, is just with regard to the deductibles. So you can quantify. I mean, I don't think it was a wise decision by Congress. I think there's many reasons for it, but I don't think it was wise at all. But in 2020, for example, the Part B deductible is $198 per year. And what it means is that the Medigap plan can't cover that. You have a deductible, even though you have a Medigap plan. So starting on January 1st of 2020, you would have owed $198 before the Medigap plan will kick in, covering the cost sharing, like copays and the like.
We have another specific question then. Are there studies that show higher income beneficiaries have Medigaps and lower income beneficiaries are in MA plans?
So MA has a higher proportion of low-income beneficiaries in it. I don't know if there's a direct correlation to why that is. There is, when you become higher income, there's a lot of things that change in the Medicare program, from how much premium you pay to like where your coverage is, and so there may be a lot of reasons why someone also with higher income can afford a Medigap plan. Sometimes a Medigap plan can be expensive. It can be several $100s a month in premiums, so that's a consideration as well. But I don't think the correlation is just income MA, low income MA, high income Medigap. I think it's individual circumstance each time.
Can I just add one thing, which is higher income people on Medicare still have retiree health benefits. And so a large chunk of the population has private insurance, not just from Medigap, but retiree health. And while we think of retiree health as eroding, because it is, that enables higher income people to stay with traditional Medicare because their supplements work. I think that may be changing rapidly, but that's still a factor.
Thank you.
So if you have a second, I will clarify. If you're in Medicare Advantage, you pay the Part B premium and the income-related premium, even if you're higher income. So that probably shouldn't be a factor in the decision-making, because the higher income premiums for Part B and D follow you wherever you go.
So thank you guys. So as we're approaching the October 15th open enrollment period and people are starting to think about this, for those of us in patient advocacy organizations that will be getting a lot of questions from our constituents about Medicare and their Medicare questions regarding pre-existing conditions, medications, et cetera, can you each share, like, beyond your own websites, which we will make sure everybody has, can you please share one resource that you think everyone should have and check out before the open enrollment period?
I will suggest that every state has what's known as a state health insurance program. Many of them are called SHIPs, but in many states, the state health insurance programs, which are funded at least in large part by federal dollars, have other names. So it's like SHINE in Florida and Choices in Connecticut. So I recommend that you go to Healthcare Locator, I believe it's called, but find the SHIP, State Health Insurance Program, in the state of residence of the person you're trying to assist. And they are going to be are tasked with helping people make the best choice and navigate this complicated system.
Tricia, Michael, suggestions?
I would agree with Judy's recommendation. I think I would just add a few more things. One is, when you're helping somebody, really think about what's most important to that person, because there's an overwhelming amount of information. And don't just go for the low-hanging fruit to compare premiums, because they're not a good proxy for cost or value. In addition to the SHIPs, which I think would be my first recommendation, if you're choosing a drug plan, not just then I think you kind of have to go to the Medicare Plan Finder, because it is the one place where you can enter your drugs, your dose level, your preferred pharmacy, and get everything you need. Just know what you're looking for, and it's all there. It's a nerd's dream site.
And most of the SHIPs can help with that, hopefully, to go in those systems for the individual.
Thanks. And Michael, suggestion?
So let me concur again with the SHIPs. Actually, that was what I would say. It's the top issue. They are not partisan. They are not tied to any specific organization, and they'll give you kind of the unfiltered information that you need. I would say, though, two important things you can do. One is call 1-800-MEDICARE. They can help you with your individual circumstance. Put your information in, spit out your drug costs or your other benefit costs. And then if you have a particular plan that you like, you give them a call. They have folks on the other end of their call who can walk you through and help you identify a plan that may be good for you, and then you can compare that to traditional Medicare and make your decision. But they can help you narrow down your options, especially if you're struggling to understand the differences between them.
Thank you guys so much. I know that there's so many more things that we could talk about and keep going on. I wanted to let everybody know that the slides from this presentation will be made available to everybody. We will also add the recommendations that our panelists just said. There'll be recording of this webinar. Thank you all for being part of this conversation today. I know there's, again, such an important topic for everybody. Please continue to pay attention to these forums. Please reach out to the Value and Information Forum groups so that you can be involved in our future quarterly programs and can suggest topics. And John, is there anything else we need to let people know today before we wrap up?
Claire, I think we should thank you for doing a terrific job as the moderator. And thanks to all of our panelists, to Tricia, to Judy, to Michael. This was super informative. And as Claire just said, the slides and the resources which each of the panelists just recommended, together with a summary of today's briefing and some additional resources that we've gathered and that were earlier recommended by the panel members, all will be made available at nationalforum.org. That's nationalforum.org. Any of those materials and the link to the recorded briefing with colleagues to whom it may be of interest and those who may not have been able to attend today. So again, on behalf of all the members of the Value and Innovation Forum Steering Committee, our panel members, and our moderator, Claire Gill. Thank you very much for attending.